While the ACL reconstruction is the current gold standard surgical approach to treat ACL tears, there are several limitations associated with it. The autologous or allogenic tendon graft does not perfectly restore the proprioceptive nerve fibers of the native ACL. Furthermore, non-anatomic placement of the graft, donor site morbidity, and decreased tendon bone healing are all the potential limitations to ACL reconstruction. While the extrasynovial ligaments can successfully heal without surgery due to the presence of surrounding fibrin clot, the ACL is intrasynovial and therefore has a limited potential to heal without surgical intervention. This occurs because the plasmin in the synovial fluid cleaves periligamentous fibrin clots, and ACL fibroblasts are inhibited by the synovial fluid. Post-ACL tears, we usually observe higher levels of plasmin levels in the knee compared to that of normal levels, because plasmin undergoes a process called proteolysis, which helps in natural healing and formation, prevention of fibrin clots, and also delays the healing. So usually complete tear or near total ACL tear always requires a surgery. It can't be treated conservatively. To surpass the aforementioned biological constraints, bridge-enhanced ACL restoration was developed. The Baer procedure involves placing a hydrophilic cylindrical collagen scaffold implant adjacent to native ACL in conjunction with primary repair. The collagen scaffold is obtained from bovine tissue and is saturated with autologous blood before implantation. It is around 15 ml that is to be injected into the into the bovine tissue. More often it looks like a marshmallow. You can imagine the implant in the shape and structure of a marshmallow. The addition of the autologous blood softens the scaffold. Sorry. Yeah, I have kept the image. Next slide. The addition of the autologous blood softens the scaffold to allow it to mold to the irregular contours of the gap between the two tone ends of the ACL, and the implant also retains the native fibrin clot at the site of injury, facilitating the release of growth factors to aid the repair process. This procedure forms a viscoelastic construct that fills the gap, providing a stable intra-articular bridging sponge to allow the native ruptured ACL to heal. The addition of implant may provide a significant enhancement to the structural properties of the ACL due to the increased cellularity within the healing ACL. The primary objective of this paper is to review the current literature regarding the Baer technique that describes surgical indications, techniques, and outcomes. Understanding these parameters can help the physicians learn about the advantages and limitations of using Baer to treat ACL injuries. The indications. The Baer trial was a prospective multi-center cohort study with a sample of 151 patients. The included patients' age range expanded to include patients between the age of 12 to 80 years old, patients with a complete tear or partial tear, and with a positive pivot shift test, and time from the initial injury of less than 50 days. It should be not close to the bone, sir. A stump has to be left. It has to be complete tear or partial tear, sir. Mid substance, sir. Probably not close to the bony ends, not to the femoral or. No, sir. Yes. Otherwise, no. Yeah. Yes, sir. Yes.
So which problem is more? Nearer to the tibia is more, nearer to the femur is gives more problem.
Near to the tibia.
Very good, excellent.
Excluded patients or patients with prior surgery or infection in the ipsilateral knee, history of nicotine, tobacco, or corticosteroid use, comorbidities or concomitant injuries, including the meniscal tears and other LCL and MCL tears. The patient must have a mid-substance or proximal complete ACL tear, been skeletally mature, and had at least 50% of the length of the ACL attached to the tibia on preoperative MRI.
That is the point. Excellent.
So what is a proximal tear? You told it is substance.
Yes, sir. Proximal tear means close to the femoral end, sir.
So that's what you are telling me.
Not close to the bone. Not a stump has to be left, sir.
There will not be tears that you want. No? There will be
Yes.
close to the bone.
Yes, sir.
The most weakest point for an ACL is towards the femoral side.
Sir.
So most common tears are also towards the femoral side. There will be no tears close to the bone, away from the bone. It's a proximal tear means it's a femoral sided tear.
Okay, sir.
Event sided tears are very rare.
Okay, sir.
You will only have avulsion injuries.
Mm.
Okay. So bare has more role only in the proximal tears,
Mm.
very less in the mid substance tears. Because it's a scaffold. No?
Yes, sir.
So that's it.
And all ligamentous injuries, you said 18 to 80 years.
Mm.
So sports injury is a different entity. You cannot combine with the routine 18 years and 80 years. Wide spectrum, that's also a totally different entity. Yes, sir. Yes, Sridhar.
So
Sports
age,
injury.
they just included the criteria, sir. They have removed the pediatric ACL injuries. That's it.
18 years. And you said 80. 80 is almost very high levels. Because everything is weak and lax.
Yes. Techniques. According to the FDA approval for bare, the surgical approach is flexible if the three core pillars of the original surgical technique are met. First, the ACL stump must be under tension and reapproximated directionally to the other stumps as the appropriate tension ensures the cells regrow in the correct direction. Second, the bare implant must be tensioned with a suture and in contact with both turn ends of the ACL stump as this maintains the implant in the appropriate location during the healing process. Lastly, the knee must be stabilized with an internal support suture. Bone-to-bone fixation provides increased support to the knee. The decision on the type of surgical instrumentation used, such as buttons or anchors, and the approach used are left to the surgeon's judgment. The original dual suspensory fixation technique was first described by Murray et al. With the knee flexed at 90 degrees, the standard ACL reconstruction viewing and working portals were created. All the concomitant pathology was addressed prior to proceeding with bare. A tibial tunnel was drilled in the anterior 25% of the tibial ACL footprint. Similarly, the femoral tunnel was drilled in the anterior 25% of the femoral ACL footprint with a reamer. A 2-inch orthotomy was performed at the medial border of the patellar tendon. The tibial stump was whip-stitched with number 2 Weichel sutures, which were passed through the cortical button. The number 2 number 2 Ether1 sutures were looped through the center holes of the button, and the button was passed through the femoral tunnel and secured on the lateral femoral cortex via lateral incision. Each limb of the looped ethibond sutures was passed through the porous end of the bare implant and then through the tibial tunnel. The implant was then infused with 10 ml of the autologous blood. Here is the diagram representing all the steps which I have mentioned. You can see the scaffold which is injected with the blood and is placed in between the suture ends of the torn tendons. And it has to be kept for a period of minimum of 8 to 10 weeks, which is degradable, sir. To start the angiogenesis and tissue regeneration, it takes a period of 8 to 10 weeks, minimum of 8 to 10 weeks. And during that period, it has to be stabilized. No, sir. It is too soft and is adjustable. Yeah. Yes. Yes, yes. It will be tight packed, but it is yes, yes. But it is degradable, so over a period of time, it will be reduced. 8 to 10 weeks. It starts resorbing from the period of 8 to 10 weeks. Sir. No, sir. Initial bracing should be done, and simultaneously we have to do range of movement exercises, physiotherapy. Yes, sir. So they have mentioned it is slowly degradable, sir. They mentioned the material is from bovine, sir. No. I don't know, sir. They mentioned, sir, it starts degrading from period of 8 to 10 weeks. They mentioned that. Yes, sir. Ethibond is not. Yes. Yes, sir.
So that's why they're talking about, that's why there is one study called LOSS. What is LOSS? Ligament Advancement Reconstructive System.
So.
Polytetrafluoroethylenes. They used to use the material. Polytetrafluoroethylenes.
Fluoroethylenes.
But this is different one.
The implant was threaded along the sutures into the femoral notch such that the porous end of the implant would lie proximally and the dense end would lie distally. The ethibond sutures were pulled distally and tied over a second cortical button along the anterior tibial cortex with the knee in full extension. The free ends of the vical suture from the whip stitch coming through the femur were tightened and tied over the femoral cortical button to move the ACL stump into the implant. The arthrotomy was then closed in the standard fashion. The patient is placed in hinged knee brace, locked in full extension, 0 degrees.
ACL rehabilitation protocol is important.
Yes, sir.
Only by non-reconstructive.
Rehabilitation. Patients were made toe-touch weight bearing in a hinged knee brace locked in extension for ambulation for 4 weeks. And patients were then allowed to advance to weight bearing as tolerated and wean their crutches at 6 weeks. Patients began range of motion exercises immediately, and the range of motion was restricted to 0 to 50 degrees of the knee flexion for the first 2 post-operative weeks. Patients advanced to 90 degrees from the second to 4th post-operative weeks. Full range of motion was permitted as tolerated after the 4th post-operative week. Formal physical therapy was started after the first post-operative week, and after 6 weeks, the hinged knee brace was discontinued under the physical therapist supervision after the patients had appropriate quadriceps function and tolerated weight bearing. Patients were, sorry. Flexion and extension, sir. Sir. Okay, sir. No. Also balancing. Patients were permitted to return to sports at 6 months to 12 months post-operatively if they had confidence when cutting, jumping at full speed, running and clearance by the operating surgeon. Yes, yes. Okay, sir. In the same paper, they have mentioned, morning, sir.
Usually they say 6 months. 6 months to more than 6 months before. Before 6 months also you had to have trials. One trial, second trial, third trial. It should be given operation.
So in this paper itself, they have mentioned after a post-ACL reconstruction, it takes around 9 months to return to sports. But this takes using the bare technique, it takes 3 extra months to go back to the normal sports activities, depending on the severity of the. It is it causes less intraoperative, and there is no chance of taking the autologous graft. And there is limited morbidity, sir. In ACL reconstruction, it takes, and there is higher chances in of re-tear in ACL reconstruction compared to bare technique. This this paper itself mentioned that. Yeah. But the study itself says that there is a high chance of re-tear in ACL reconstruction. Yeah. Yeah, I mentioned, sir, in the last slide. I mentioned. Yes, sir. And as it is a recent advancement, the post-op results has to take some more time to see the complications, later complications. So outcomes. Patients treated with BER had full range of motion after surgery, satisfactory patient-reported outcome measures, and a relatively low complication rate. Functionally, the patients returned to having a full range of motion in all trials of BER. They had similar biomechanical data regarding the anteroposterior laxity. This can be tested through a test called KT1000, sir. Yeah. The BER cohorts had. Sorry. Yeah, we have to place a device and strapping over the leg and one over the tibia. And if the laxity is more than 5 mm, then it can be considered severe. The BER cohorts had significantly superior hamstring strength and no difference in quadriceps strength compared to ACL reconstruction cohort, which could be due to nearly all the patients in the ACL reconstruction cohort receiving autologous hamstring grafts. In comparison, there were zero raters in BER population. This is the point where they mentioned, so. With an average follow-up time of 6.3 plus or minus 4.1 months. This is the mean value. These re-tear rates are in range compared to established 2-year ACL reconstruction re-tear rate ranging from 1 to 20%. So the higher end is 20%. No, sir, it's not like that. Yes, sir. Yeah, it is not a promoting thing, sir. Like, I'm just showing the alternative method to the ACL reconstruction. As ACL reconstruction is the gold standard one. These re-tear rates are in range compared to the established 2-year ACL re-tear rate ranging from 1 to 20%. 3 patients in the BER cohort, that is 5%, developed arthrofibrosis, stiffening, out of 151. 150, so 151. The current ACL literature, ACL reconstruction literature has an arthrofibrosis rate ranging from 2 to 35%. Knee stiffness also then. Arthrofibrosis. Yes, sir. Scaffold. We can experts. Tight packed. Conclusions. This review summarized the current literature regarding the BER from the initial trial to the current state. The results from the BER trials were encouraging. However, it remains uncertain if this novel procedure can outperform the current gold standard ACL reconstruction in the long term. Future studies are needed to confirm the long-term efficacy of this novel approach to treating ACL tears. There is one more paper I have seen, same, sir, the outcome. After 6 years of the follow-up, more patients gained pre-injury range of movements with BER compared to that of ACL reconstruction. And again, I'm not promoting it, just showing the results. 2023 one. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So that's why they say in sports injuries, earlier where we used to do ACL reconstruction, that is hamstring reconstruction. But in case of sports injury, high demand people, it is the bone, ligament, bone. That is more important. Ligament, patella ligament, patella ligament, and tibial tuberous. Bone, ligament, bone. That is more indicated. But that is a native. But this is synthetic. Whatever is. That is the reason why they are going with the loss. You said after 2 years or something like that. So whatever the scaffold you start absorbing itself between the joint because of the content of the fibrin and hyaluronidase, it is slowly going to degrade by the end of 2 years. And 8 years is already, the bones are weak, everything is weak and everything is lax. So you cannot achieve the 100% results.
Sir.
That's why they're using loss. Ligament advancement reconstructive system. The totally new one. That's totally new one. So there is nothing like resorption and loss. Yes, Srikanth.
Chandrakant.
Yeah, Chandrakant.
So these were the cases done in Unit 1. 27-year male with closed distal third both bone shaft fracture of the right leg with neck of the fifth metatarsal fracture of the right foot, sir. And also there is a fracture of undisplaced talus and calcaneum. Undi, sir. CT you can see. Zoom jara konచెం. 3D పెట్టు, sir. Last కూడా పెట్టేసాను. Road traffic accident, sir. He fell from my bike. Fell from my bike.
I'm sure you've done many, seen many. Yeah. So what was the problem? So are you happy with the reduction? So reduction is not right. Who did surgery? Lakshmikant.
Jairam, maybe
Huh?
Jairam, sir.
Jairam. Yeah. So anyway, that so reduction, basic thing is you must reduce because you should be able to achieve primary stability from fracture reduction.
Lateral cortex is intact. Probably it is a reduction problem.
Maybe soft tissue interposition because the IDS source
The lesser trochanter is avulsed.
maybe little attached. That's why maybe possible.
But the two main fragments, they did not get into good contact.
Combination 65. So
70 years.
65 you wrote top. X-ray says 70. Who is right?
65, sir.
Not 70.
No, sir. August is 70.
All right.
A radiographer must have put a wrong at the time of injury.
So basic thing is reduction was not achieved, and of course subtrochanteric unstable fractures. It should be a long PFN, not short one. No. Okay, go. Shows the latest. So this is current status, is it?
No, sir. This is the current state.
This is the current status. 12 weeks now. So what do you want to do? Pradeep? Or anybody else? Any senior residents? Nobody. What do you want to do? Sridhar?
So there is negative reduction and distraction at the fracture site.
Yeah. So what is the minimal thing you can do without disturbing much? Can you use the same?
Implant is stable or not?
Yeah.
Primary point that has to be
Yeah.
taken. Implant is stable.
Try to dynamize.
Local biology.
You can remove the static screw and try to dynamize.
Without doing anything.
Without lifting the side.
Yeah.
Put a bone graft.
Simple dynamization.
Bone graft is too long for bone graft. The space is too long. But what you can do, probably, you can take these screws out and impact. Maybe try to reduce it. Open up, reduce it, and put the screws back. And maybe.
You may disturb it much more by removing and open it up,
Ah.
clear all the fibrous tissues,
Yeah.
brush in the end, put a tricortical good chunk of bone graft so that the cortical continuity is restored. Good tricortical.
Yeah, probably. But see, so much of gap is there.
Can breathe because the implant is quite stable. And put a small augmentation plate.
Yes, that may be. But don't you think if you take this one out, push up,
I don't think so.
it won't?
There is so much of fibrous tissue around.
No, open up. Open reduction and take this one out and put it back.
Theoretically appears okay.
Practically difficult.
So well that it gets closer.
Closer, that one.
Subtrochanter, they said that you have to overkill, sir. So you have to put a bone graft, augmentation plate, do everything else.
Plate augmentation I think should be okay for this.
And see this one, so much of gap is there.
Put a tricortical graft between the two fragments with good contact with slivers of bone graft or allograft.
Here says 77.
Plate augmentation is very important.
Yeah, you're right. Supplemented because this is not going to hold very long. So this age, whatever you've written, they'll write it in the X-ray. Radiographer is not going to make the age. On the prescription form, you write the age and name, isn't it? That's what, this is your mistake. Initially 70, 77, now 65. Okay. I think probably that one, but I still feel, may be difficult because this wider part may not come down, is it?
from 15 days she is weight bearing, sir. We advised not to.
But this fixation is good, isn't it? And see, the cortis is very, very thick, the good quality bone. She may not be 65. Because needs intervention. You can't leave her like that. Okay. Done?
Good morning, sir. This is a 65-year-old male, compound, grade 3B comminuted, distal third both bone fracture of right leg, sir.
Third case. Series.
We have done external fixation for right tibia and rational for fibula, sir.
Go back, go back. What was the reason?
Yes, sir, that is a bone fragment, sir.
Okay. Primary fixation was how many days old?
This is a fresh case, sir.
We could have fixed it.
There's
was
a
it?
lot of combination is there, sir. And
How old is the patient?
65 years, sir.
Huh?
65 years.
65. No, 65.
Maybe.
But you still can. Combination is no indication, not a contraindication for
It's
internal
compound.
fixation.
Also, yes, sir.
Well, wrinkling is there. It's not.
These are abrasions
This is
are
lateral
also
side.
there. Yes, sir.
They can put a plate on the medial side. But you put because this is not going to be permanent, is it?
Yes, sir.
to
Second
take it
fixation
out.
is planned after 6 weeks.
What happened? These people will leave it. Few weeks later, it become more osteoporotic, and it would be difficult to hold. So the best opportunity will be initial stage to fix it.
Yes.
Okay, go on. But reduction is good.
Yes, sir.
Reduction is good. Probably might heal up. Go on. Next. BMAC maybe. Yeah. Maybe take this one out, put a proper plaster, and then do. Yeah. Okay.
22-year-old male cell with a 9-year-old middle third shaft fracture of right femur with implant in situ. We have tried implant removal for right femur, sir. But
Do not. How many years?
9 years old, sir.
9
At
years.
the age of 13 years, he has a.
What was the indication for removal?
He's complaining of pain, sir.
Where is the pain?
Here, towards the lateral side of the thigh.
Okay. Thigh.
Yes, sir.
What was the reason for the pain?
Maybe the plate protruding on the tissue.
It will be in the tissue. Because well fixed, well united.
Yes, sir.
I don't see any reason for the pain. He's not going to, I think now he's going to get more pain. That's what happens most of the
Yes, yes, sir. Yes, sir.
They were, you broken or already broken?
No, sir. While we are trying to remove the.
Remove it.
Yes, sir. Yes, sir.
So now it is something like cold welding. James, sir, cold welding is different.
Co- cold welding happens in only locking screws. This is damaged, this one. What is that? Head. Damaged. That's now expected after 8 years anyway. But you can, too many holes, you can hollow drill. You can
Yes, sir.
drill
We
it
tried,
and
sir,
then-
for one thing.
That's okay. I don't think it's going to cause any problems.
Yes, sir. We explained it, sir. We explained them. We explained. Yes, sir.
Explain and document it.
Yes, sir.
Did you write in the notes?
Yes, sir.
Yeah.
Yes, sir. We
Consent.
have taken the consent, sir. That's
When you take a picture for feature, this one, you put a clean one. See, blood stained. That shows how much care you've taken in taking pictures.
Yes.
Good.
Thank you, sir.
So these are, you should take home messages. You have to be expected. Implant removal becomes sometimes more difficult than putting inside. So you should explain and
Yes, sir.
convince patient. If you're asymptomatic, don't take them out. You're not going to get any problem. Okay.
Thanks. That's it. That's it.
Done now. Okay, very good. How many cases are pending? Unit 1? 8. Unit 2?
3, 5, sir. 5 cases, sir. Sir. Okay, sir.
How is the topic?
Excellent, marvelous. Good. You have given focus the light. In fact, you have what do you call? You have showered the thunders onto the topic.
That's a lot, sir.